A very good morning, everyone. I'm very thankful for you all being here. I'm excited to share my progress for over the past 9 months. Title of my PhD work is Evidence-Based Solutions for Orthodontic Acceleration. My name is Nazanin Ghods. I'm a dentist and first-year PhD student. My supervisors are Gabor Varga and Tibor Zeles. I would like to transform orthodontics with effective non-surgical solutions by delivering evidence-based solutions for orthodontic acceleration. I have 2 ongoing projects. First one started on September 2024 and the second one on November 2024. My first project is investigating the safety and efficacy of non-invasive accelerated orthodontic techniques in adult and adolescent orthodontic patients. More than 5.75 million patients per year only in US and Canada are undergoing orthodontic treatment. This treatment lasts up to 3 years with pain and a lot of complications. As a result, 1 out of 4 patients decide to discontinue their treatment. This leads us to accelerated orthodontic methods, which these methods can be light-based therapies such as laser and LED. They can be electromagnetic field therapies. They can be electrical therapies, or they can be mechanical therapies, such as vibration and ultrasound. These techniques work in a way that when mechanical stimulation increases, there will be increase in the blood flow, and as a result, healing is going to be stimulated. That's why our aim here is to identify patient-friendly, effective, non-invasive, adjuvant treatment that minimize treatment time and risk. Clinical question here is, do accelerating methods combined with fixed conventional orthodontic treatment shorten treatment time and reduce post-activation pain? And we're hypothesizing that using these techniques alongside with fixed conventional orthodontic treatment does lead to faster tooth movement and it decreases post-activation pain. We're using PICO framework with population of adult and adolescent patients undergoing orthodontic treatment. Our interventions are the techniques we already discussed, and our comparator is just fixed conventional orthodontic treatment. We have several outcomes, which the primary is rate of tooth movement, and the rest you can see, with the clinical implications of guideline update and increased patient satisfaction. Our search strategy is structured in 3 domains. Second domain is basically summary of all the interventions we're discussing, and on the third domain, we're making sure we're covering only trial articles. We conducted our search key in 3 databases, PubMed, Embase, and Cochrane Library on 14th of November. First, we started with 3,518 articles, and after our selection process, we found 85 articles. We also did the citation chasing process, which we found 36 new articles meeting our inclusion criteria. I have 1 finished analysis, which I will show you in the next slide, and several ongoing analyses, which they will be subgrouped based on the treated jaw, type of intervention, number of tooth, stage of treatment, and whether they used placebo or controlled group. Post-initial archwire placement pain, day 3, is title of this forest plot. Initial archwire placement is often known as one of the most painful stages in orthodontic treatment. Pain also plays a crucial role in every treatment, especially true in orthodontics. When the pain level is too high, it affects patient satisfaction, cooperation, and even their quality of life through the course of treatment. So the key takeaway here is that if we can effectively manage and reduce pain level, not only we can improve patients' quality of life, but also indirectly we can increase success rate of our treatment. The unit of pain here is numeric rating scale and visual analog scale, both ranging from 0 to 10, which 0 means patient felt absolute no pain, and 10 means the patient felt intolerable pain. We had 2 groups of laser and placebo group with approximate population of 360. We used 5 articles for this forest plot, which unfortunately for 2 of them standard deviation was not provided, so only 3 of them came into calculation. All the articles were clinical trials, and 3 of the articles' means have been manually calculated with the help of Stats to Do website. Heterogeneity here is 0%, but checking our confidence interval range, not necessarily it means that we have low heterogeneity, but rather that we don't have enough number of articles to measure our heterogeneity according to. Our pooled mean difference here is approximately -1, and considering our confidence interval is also below 0, suggests that use of laser in reducing pain is mathematically and statistically significant. Also checking individual data, as an example, Sayyed Hassan, change of mean in the placebo group of 2.5 to 1 in the laser group might not seem to be a big change, but considering use of laser reduced this pain by 70%, can suggest that laser as a non-pharmacological, non-surgical option can be clinically significant in reducing post-initial arch wire placement pain. At this stage, we're done with risk of bias assessment and we're waiting for more and more plots from our statistical team. My second project is investigating the accuracy of semi and fully automated cephalometric analysis in orthodontic patients. More than 5.75 million patients in US and Canada per year need orthodontic treatment and cephalometric analysis. Cephalogram is a radiograph of sagittal plane of head, which there are several landmarks that are joined together to form planes and angles. With the help of plane and angles, we can analyze dental and skeletal anomalies. This analysis can be done in 3 possible ways: manual, semi-automated, or fully automated. Now, imagine you're an orthodontist with 200 new patients per year. You have 2 possible options to do your analysis. Either you do it with fully AI or you do it manual. If you do it with fully automated, this analysis takes 30 seconds, which in the manual way, it takes 30 minutes. As a result, if you choose the fully automated version, you will save 100 hours in 1 year and less error rate by 30%. By error, I mean variability, landmark identification, and landmark measurement, which these errors will lead to inaccurate diagnosis and treatment plan, and that's not what we're looking for. So our aim here is to identify fully automated cephalometric analysis for its landmark detection accuracy and speed. This leads us to the clinical question that does fully automated cephalometric analysis provide similar or better measurement consistency and workflow metrics than semi-automated and manual methods? And we're hypothesizing that use of fully automated cephalometric analysis does provide similar or better measurement consistency and workflow metrics. For this project also, we're using PICO framework with population of orthodontic patients requiring cephalometric analysis. We have 2 interventions, fully automated cephalometric analysis and semi-automated, and our comparator is gold standard, manual cephalometric analysis. We have 2 sets of outcomes, measurement consistency and workflow metrics, with clinical implications of increased accuracy and guideline update. As an example, I can show you a set of my key articles. I color-coded the outcomes based on the primary and the secondary outcome. And the article that I color-coded is an article that simply compares manual with semi-automated and fully automated. For the summary, my first project is expected to end on September 2025, and the second one on November 2026. And at the end, as I conclude, I would like to leave you with a quote from the Persian poet Saadi Shirazi: "Have patience, all things are difficult before they become easy." Thank you for your attention.
Thank you very much for your presentation. Any questions from the audience?
Thank you for your presentation. I have a question regarding your second project. So what do you think will be the future of AI in orthodontics? Have you come across, for example, AI treatment prediction?
So that's a very interesting question, because I was originally planning on making the second project as like role of AI in orthodontic planning, but as I check more, since we're working with meta-analysis at this stage, there are not many articles that we can use in our meta-analysis regarding the diagnosis. There are several, but one difficult thing with AI is that they use different neural network system and different algorithm. So it's really difficult to compare them. But what that is available in database now is mainly with help of AI in prediction of extraction planning. So that we can, if you're interested.
Thank you very much.
Thank you for your presentation. I have a question for your first project. In the population, in the first project was the adolescent and the adult. It is the good option to pool them, one population, or do you plan to check the subgroup analysis?
For the pain, regarding pain, I know it plays an important role because adults, they have high tolerance level, but adolescents, they have lower tolerance. So we're planning to make subgroups on outcome, let's say, like pain, but I think for the rate of tooth movement, it depends on the number of the articles that we have. But the more subgroups we will have, the more accurate the plot is going to be.
Yeah, because it's not only the pain tolerance, but the regeneration answer and everything it's different between the two groups.
True.
Mamnun Nazanin. I want to ask about your first project because I'm very curious about your forest plot. Because in your forest plot, I saw 2 articles in the top. Mm-hmm. Can you tell me what happened to these 2? Because I can see asterisks, but I cannot see the labels. So can you present this for us?
So the problem with not the problem, but the issue that we had with the first 2 articles was like the numbers were basically on the line graph. And they did not provide the standard deviation. So only thing we could find from the graph was the mean. So that's why we couldn't really, without having the standard deviation, we couldn't really mathematically do the calculations for the forest plot. But I'm not sure if we can say it or not, but they had a good result because specifically the first article, the seconds after they applied laser was way higher than the other articles. So I assume maybe that's why that the number change is much higher. Because in the other articles, let's say like Ahrari or Ramaya, they put laser for 20 seconds, 10 seconds. But for the first article, Tortomano, I assume, they put 120 seconds. So that's why they had a good result, but unfortunately we didn't have the standard deviation.
And do you think you can use a subgroup here or just take those 2 articles out because maybe it can cause some kind of bias in this case? I don't know if you discussed this, but I think this should be discussed later if you haven't.
Of course.
Okay.
We will definitely have more plots, but because this is a placebo one and we had limited numbers, so we could use it for the booster statistical analysis. But there will be more and more plots with like laser and control group, which they will be regression analysis. So by over the time we can analyze the plots, but I will take them away.
Thank you very much.
Thank you.
I have a question regarding your second topic. I would like to ask, what was the gold standard? It's okay, yes, AI does reduce the time to perform the analysis, but what about accuracy? What is the gold standard that they use in these articles to check AI?
So the possible option that they do in most of the articles to check whether there is enough accuracy in analysis is that, first of all, they do it blindfoldly, and they used, as an example, like 5 different dentists to analyze, and all the dentists analyzed the same cephalometric analysis blindfoldly without knowing the other person's analysis. So that's how they did it. But in general, gold standard is the manual one. So they print out the cephalometric analysis, they put a paper, they do everything on the paper, but the method that they use most currently these days is that they put on the cephalometric on the computer screen and they manually put the dots and the points and then they measure. But the gold standard is the manual one, the